For putting this on and for asking me. This talk got swapped around through a few sessions, so it sort of ended up a little different to how it started. So it does have a slightly arthroscopic bent to it. I'm not a radiologist, and so this has been very much geared towards the sort of things that are important to reshaping hips, not so much important if you're just going to cut it out and put in a hip replacement. Standard sort of disclosures, but none of them are relevant to this. I just wanted to put in a quick word. I gather there are only 6% of people at the meeting who had any interest in hip arthroscopy this morning, so I'm talking to the very small percentage who might be here, but I'd strongly encourage you to join the International Society of Hip Arthroscopy. It's the only society that's geared towards this, and I think you'll find a great group to join. The next meeting's in Rio de Janeiro in October next year, so a lovely spot to go. Obviously, the starting point for any X-ray talk is X-rays. For hip arthroscopy at least, and I guess for hip replacement as well, the real gold standard to the whole thing is an AP X-ray of the pelvis. It's very important that it's done properly, otherwise it's misleading. It has to be well centred, it has to be tilted correctly so that the gap between the tip of the coccyx and the top of the pubic symphysis is 1 to 3 centimetres. Otherwise, as Tanis has shown with his X-rays that he took with wire markers, if you tilt the pelvis or roll it from one side to the other, you'll distort all of the anatomy and it will give you a totally false idea of what the situation is. So it's critically important that the X-ray is done correctly. The standard X-rays we get for laterals, at least in Australia, are these, which if you want to reshape the femoral neck are obviously useless because it's so distorted by the overlying trochanter, it tells you nothing. So I think in North America it tends to be frog leg laterals that are done more like this to see the femoral neck, and the ones we use are done views, which can be done at either 45 degrees of flexion or 90, which give a really nice view of the femoral head and neck junction, and will show you the area where the bumps are where the cam lesions are likely to be. And also correspond to what we see during surgery, where we can compare them to the 90 degree or 45 degree duns and get exactly the same shot on an image intensifier and know that we've corrected it the way we wish. Obviously acetabular version and volume are important as well. We can look for the so-called crossover sign, which is apparent overhang of the anterosuperior part of the acetabular wall, but you have to be careful again with this. Bear in mind these are just two-dimensional shots, and there's all sorts of things can distort them, and we'll come to some of that shortly. Sometimes called focal pincers, also called acetabular retroversion. But we look for the anterior wall and the posterior wall. Sorry, I don't think I have a pointer, but they correspond, so the anterior wall in red and the posterior in blue. But we do need to be sure that there's adequate posterior wall and it's not just retroverted, which is making the anterior wall seem prominent, because there's actually a deficient posterior wall. And if we go and remove a whole of anterior wall, all we're doing then is creating a dysplastic hip. Also, it's been shown with three-dimensional CTs that a lot of the so-called crossovers weren't really acetabular retroversion at all, and what we're actually looking at is part of the anterior spine, anterior inferior iliac spine. So again, take care. Don't use one X-ray and make all your decisions on one X-ray. Take into account a whole lot of other things as well. We need to look at the posterior wall again to make sure that it's not deficient, so that when we remove some anterior wall we end up with a totally deficient acetabulum. There's a lot of information on a plain X-ray, so you don't need to go to scan straight off. So I've just put arrows on these, but you can see the apparent crossover at the top, the relatively medial posterior wall, the iliac spine that you can see, which is again indicative of retroversion of the acetabulum. So there's lots of information we can get. The trouble is it's not necessarily accurate. We also want to be careful of dysplasia, so not just the lateral centre edge angle. It's important to look at a false profile view so that we can see the anterior centre edge angle as well, because treating dysplastic hips without realising they're dysplastic and doing arthroscopic surgery on them can lead to absolute catastrophes. And I find that the Tanis angle is probably the most useful one of all because it's the most reproducible, and if the angle of the sourcil at the top of the acetabulum is between 0 and 10 degrees, you're going to be pretty safe. If it's more than that, then it's almost certainly dysplastic, and if it's negative, then it's overhanging in a deep acetabulum, and I find that very useful. MRI can be helpful. It tends to show more the intra-articular problems that go with impingement, for example. So things like the impingement cysts, which used to be known as herniation pits and said to be normal, but which aren't, they're indications of impingement. You can see the damage that goes with that to the chondrolabral junction, also indicating impingement type damage. So MRI is very useful for that. Better MRIs with 3T magnets can show you damage to the articular cartilage, but most of them I don't find very reliable. But that's very helpful in giving you an indication of the likely outcome of your surgery. Sorry, a big pun. The last one was incomplete tertiary labrum. This is, and again, chondral delamination, which again is not totally reliable, but when seen well like this is really very helpful. That can give you an indication to say to the patient that there is damage there and that is going to compromise the long-term outcome of the surgery you're about to do. You can certainly do your measurements on good quality MRIs as well for things like alpha angles if you want to. They can show the posterior damage that goes with contra-Q lesions that you may well not see on other methods of imaging, and again give you a better idea of how much damage there is in the hip and compromise to outcome of arthroscopic surgery. Again, be careful, not everything you think you see is correct, and where the arrow is pointing slightly to the left of it, is often reported as a labral tear when in fact it's just a sulcus, and these folds can occur at any position around the acetabulum and are often mistaken for tears. So MRIs are good at reporting labral tears, but they're not always there, and most of them are in fact chondral damage. They are pretty helpful though at picking up things that you may at a glance go past on a plain X-ray such as AVN, and obviously they're important things to know about before considering any surgery, especially what's about to become inappropriate arthroscopic surgery. Better quality scanning to look at articular cartilage is certainly here, but not totally reliable either, but it's certainly getting better. So degeneric scans to look at articular cartilage or T2 mapping as well. You have to be a little careful because with all the pretty colours it makes it look very definitive, but it's not as reproducible or as accurate as is made out. But again, it's a step in the right direction and gives better information. CT we find very useful for preoperative planning. We tend to do it in a position where the hip is flexed, adducted, internally rotated, sometimes called position of discomfort, POD, but it actually stands for Pritchard and O'Donnell because the two of us developed it, but it's been sort of hijacked somewhere along the way. It does give you a much better view. So this is the same patient who had the scans done twice by mistake, but one was done in that position and one was just out straight. You can see how much better you can see the area of impingement on the scan that's in that position. As well, it better shows you loss of articular cartilage because it's a little like a standing AP X-ray of a knee. With that additional stress there, you can see the loss of articular cartilage better. And that's comparing the 3D reconstructions again in those positions, so you can see the impingement on the left much better than you can on the right, where you can't see it at all, but you can see the shape. Lots of other information you can get, but you know all of those. So in terms of alpha angles and actually planning, if you take a slice through the knee as well, you'll be able to get femoral version, which is important because that may of itself be a cause of impingement without cam lesions, etc. And it's helpful in planning if you're going to remove an os as well, because you want to be sure you're not about to create a dysplastic hip. So on the CTs you can plan that part of it much better as well. And in revision situations they're extremely helpful both to tell what's been done already and what you plan to do. Virtual models, there'll be more talks about these, so I'll only very quickly gloss over it, but there are several systems, or at least two that I'm aware of that are available. This is the one I use at present. Where you can get the CTs done, you can virtually do the operation, you can test a range of movement before and after, and it's very helpful in planning whether you should take bone off the femur or the acetabulum or both. And there's the system that's downstairs here as well, which again does the same sort of thing. So there's all sorts of new things that are coming along. There's lots of old tests that are done regularly which are helpful. There's new systems that are coming to help us better plan arthroscopic surgery particularly. And I'd also like to ask you to come to Melbourne in January because it's a lovely spot, and I'm not allowed to mention the tennis is on, but it's somewhere close by at the same time.